Are trickling in. I'm Laura Pritchett. I'm Administrative Director of the BEAD Core, the Biostatistics, Epidemiology, and Data Management Core. We are sponsoring this seminar today, the last in our winter seminar series. Just briefly, the BEAD Core provides research support services to faculty at Hopkins. Specifically right now, we are sponsored by the Departments of Pediatrics, Medicine, Gyno-B, ACCM, and we have a pilot project with PM&R. And so those faculty and trainees get free or sponsored hours to work with us in a lot of different research support areas. We also have a line that supports patient-reported outcomes research for faculty and trainees throughout the entire institution. And we're also available on a fee-for-services basis for anyone who's not in one of our sponsored departments. So anyone who's interested in accessing our services, please email beadcore@jhmi.edu, and we would be very happy to set you up with someone to help provide any needed research support services. And we actually provided support to this project that we'll hear about today, or at least some part of it. And so without further ado, I want to welcome our presenters today. We have a dream team for you. This should be really interesting to talk both about how PMAP is used in practice and about specifically some of the research in this pediatric emergency space. We have Oluwakemi Badaki-Makun. She is an assistant professor of pediatric emergency medicine, the director of research in the Pediatric Emergency Department, and faculty at the Center for Data Science in Emergency Medicine. And her research focuses on utilizing AI, machine learning, and big data for predictive modeling to identify and improve treatment for acutely ill and injured pediatric patients. We have Daniel Hindman today. He is an assistant professor of general internal medicine as well as pediatrics, works in outpatient and ED settings. And his research is focused on the interplay between community and environmental factors and health, and also social disparities and telehealth research. And finally, Amyna Husain is an assistant professor of pediatric emergency medicine. She is the director of pediatric emergency disaster management, and her research interest is in disaster preparedness nationally and regionally, and I don't know, internationally. I'll let them give more information, and they'll be able to answer specific questions after each of their portions of the program. And feel free to either put questions in the chat or to go ahead and unmute yourself. So welcome everyone. And without further ado, Kemi, I believe you're going first.
Yes, I am. So I will go ahead and share my screen. And thank you so much for inviting us to share some of our research over here and our work with PMAP. I am, hopefully now everyone can see the PowerPoint presentation. Yes. So basically, we are going to be talking about some of the projects that we've used the PMAP database for in our COVID kids group. Have nothing to disclose. And so basically what we'll have today is I'll give a brief introduction of the PMAP database in terms of how it can be used and how we've been using it, especially connected to the Center for Data Science and Emergency Medicine. And then Dr. Husain will give an overview of some of the studies that she's been focused on in our group, and then followed by Dr. Hindman. So I'll just start off by introducing PMAP, which I'm sure you're all familiar with. It's the Precision Medicine Analytics platform. And a lot of these images are from the website, which I listed at the bottom over there. But basically, in a nutshell, what PMAP does and what's really very interesting and cool about it is that it brings together data, very granular data from multiple sources. So as you can see here, from EPIC, so our main clinical electronic health record system, but not only that, it can pull data from multiple other areas. So usually we have imaging data in there, as well as data from multiple monitors within the hospital, patient monitors, but then also very specifically, if you have research REDCap databases or other databases that could be pulled in as well, in addition to other data sources. And so all these things, all these forms of data are pulled in to a central database, which and then can be analyzed, can be put together to be analyzed, and usually in a SQL system. And so usually these data are pulled together into the data commons. And from there, what often happens is when you request access to PMAP data is that a projection can be built for you. And so what ends up happening is all that data is available in the data commons. All those data are available in the data commons. And then specific to your study or your project, projection can be built for you in a SQL database, which you can then use. And so this is the process that we went through in order to be able to get some of these studies done. And we worked specifically through the Center for Data Science in Emergency Medicine, which is a center that's housed in the General Emergency Medicine Department at Johns Hopkins. And the center is a multi-talented group of people that includes engineers, data scientists, and clinicians who work together to improve outcomes for patients in the emergency department. And so here are a sample of some of the studies that we work on in the center. And I'll highlight one that really does take the PMAP work from the beginning all the way through the end. So this one is the connected emergency care. And basically the premise for this project is that there's so many factors that come together to affect patient outcomes that are a little bit out of our control sometimes in the emergency department. Things such as the absence of a longitudinal relationship between a patient in the ED and the physicians that they are seeing. Clearly, that's not how the emergency department is set up. We're not supposed to have a lot of continuity of care. And sometimes there's missing clinical information. And so you get to know less about your patients than you would in the clinic setting, for instance. And there's sometimes a lack of clinical decision support. And then usually there's a lot happening all at the same time. We're in a fast-paced environment. So this particular study was looking at how to harness information from the health record, so the PMAP data, how to harness all that information and how to then turn it into a usable format for patients, for physicians to be able to follow up on their patients, number one, and see how their patients have done in order to be able to learn in a closed loop system about how best to treat that kind of patient coming forward. And so this is an example of where PMAP is used in the development of the data set that we need to use. And so raw data is pulled in and data is normalized by our computer scientists and engineers. It's cleaned, and then using multiple different modeling tools, you end up putting that into our servers and then sending it over to the Tableau, which again is something that the PMAP system can help set up for you. And so there's actually an active dashboard. There are multiple dashboards that the Center for Data Science works on, but there's actually an active dashboard for this particular project. So this one is an example of what PMAP can do in terms of taking raw data, analyzing the data, normalizing it, using it turning it into a format that can be utilized in the clinical setting. And so here I was just going to go show a very brief video of what the loop system is. Again, just sharing what work is being done here. Oh, I see I've lost my screen. Excuse me. Let me just share it again. All right, there we are. I'll just share the direct video. Actually, that'll make it easier. But the point here being that now we have, using PMAP data, you're able to, in real time, develop feedback loop systems in order for practitioners in the ED to actually be able to follow up on their patients in the system.
Clinicians have no established relationships with the patients they treat and often have no idea.
And hopefully you can hear the screen here.
Due to the number of patients seen on each shift, it can be impossible to follow up on all cases. Using handwritten or manually generated lists in Epic can help, but it's hard to catch everything and understand trends in patient outcomes. Coupled with the daily demands of the job, balancing caring for more patients every day, patient review and knowing outcomes becomes an exponentially difficult task for physicians. Loop takes the work you've already generated about your patients and looks for outcomes over time. Data scientists clean the complex electronic health record data for the simplest understanding behind the scenes. They look for a variety of outcomes, including in-hospital mortalities, elevation in care or bounce-ups, and 72-hour returns. Designers on our team worked with your colleagues to understand the wants in each of these outcomes and design the dashboard to be quick while prioritizing exploration. What would take 30 to 45 minutes in Epic takes less than a minute in Loop. In 2 years, Loop has moved from a question on how to understand outcomes better to a place to explore our care deeper. You can find Loop in AgileMD and Epic, on the Hopkins intranet, or by bookmarking the link in email. More outcomes are coming soon to Loop, including stroke outcomes, sepsis, antibiotic resistance outcomes, and COVID-19.
All right, so that is just an example of one of the projects taking the PMAP work from the electronic health record all the way through to a bedside tableau that actually is in use and can be used for patients, for improving patient care. So I'll move on from that to just talking very specifically about our projects in the COVID Kids group and some of the work that we're working on here, and then I'll pass it on to the rest of our team. So here, let me make sure my PowerPoint is showing clearly again. There we go. And so, so COVID has definitely caused some significant disruptions to our lives, clearly. Our team, the COVID Kids group, came together to evaluate how COVID specifically was affecting pediatric patients, which early on, as you might remember, pediatric patients were not seen to be at significant risk for COVID and were not seen to have significant poor outcomes. Of course, as time has evolved, we have seen that that is not completely true. And some of our work, for instance, is focused on multisystem inflammatory syndrome in children. So this is a syndrome that is defined by significant fever plus one or more symptoms involving the GI tract or the skin or other cutaneous findings. So this syndrome, I would just like to highlight here, the main presenting complaint is ongoing fever. So for one of our studies, we looked very specifically at fever in patients in the emergency department and how our management of patients with fever has changed. We wanted to understand that better and also understand better how to try and diagnose this syndrome, MIS-C. So this is one of the studies that we use the PMAP database for, where we evaluated how much testing we were now doing for patients with patients presenting with fever in the setting of COVID and then with the concern for this syndrome MIS-C in the background. And so what I'll just like to summarize in the data here was that we were able to see very quickly that we had started doing much more testing once COVID came. So this is looking at different months over the course of the year, between the years 2018 to 2020, and the gray is 2020, and looking at one specific set of our tests that we don't routinely obtain in patients with fever, but which we was required for the diagnosis of MIS-C. And so you can see just very briefly here, very clearly, that our use of these tests, a CRP specifically, increased significantly in 2020 after the first case reports of MIS-C came out. There was a really large increase initially that summer, but since then it's been pretty persistent over the course of time. And so this was just one of the studies, and Dr. Hindman and Dr. Husain are going to talk about in much more detail about the other studies. But I just wanted to highlight those as just highlight PMAP as a whole in terms of how we've been using it and how the potential that it has for improving care in our patients. All right, I'm going to stop sharing there and ask if people have questions for me at the moment before we move on to the other presenters.
All right, well, I will go ahead then. Kemi, you good with that?
I'm good.
Making
Yeah.
some questions, we're happy to circle back and answer more. So my name is Daniel Hindman, and I'm going to pick up the presentation at this point and talk a little bit about some background for the studies we'll talk about as we go along. So the people involved in this work are listed here. The only person not listed here that I'd like to make sure I mention is that in the particular study I'm discussing, Anna Samuels has been an important contributor as well as we reviewed some of the algorithms. There we go. There's no disclosures, but I did want to make sure to mention that we did have a funder for this study, as well as what Amyna will be talking about, or Dr. Husain, in a little bit. And that was the Emergency Medicine Foundation, and we're very grateful for their funding to help do this research. So by way of background, I just want to take you back to the beginning of the pandemic and try to remember what it was like when things started and how it went. Early on in the pandemic, the focus very much, and appropriately so, was on the adult world. We knew that adults were getting really sick, and lots of adults were. But as reports came out of China and as things developed here in the US and in Europe, there was also increasing recognition that kids got COVID too, that they did get sick, but there was also this background sense that they had lower morbidity and lower mortality. And eventually studies showed that over time and have demonstrated on a repeated basis the decreased rates of morbidity and mortality in children in terms of hospitalization, death, and so forth. But in the beginning, that was the general sense as well. But you add that also to the fact that in those early stages, in addition to limited knowledge, as you'll recall, we also had very limited resources. Again, going back to those first couple months of the pandemic, one of the challenges was we just didn't have enough testing supplies to go around and use testing like we wanted to. And then on top of that, we didn't have the personal protective equipment. And if you put yourself in that place of having one population who has higher morbidity and mortality and another with lower morbidity and mortality, right? So adults versus kids, you have limited resources. How do you decide what goes where? Especially when challenges are shared across those populations in a single health system. And that's really the basis for the work that Amyna and I want to talk about today. You can think of lots of questions that would come up in this context, right? One is, how do we conserve critical resources for those who need them most? If we only have so many tests, who do we decide who to use them on, right? Or how do we make sure that PPE gets rationed or used in a way to where it's actually getting the people that most need protected and that are most likely to have COVID? How do we help pediatricians know who to test? We have people delivering care at all kinds of sites, inpatient, outpatient. How do we give them any kind of guidance on how to use tests to help conserve resources that are critical in a resource-constricted, scarce environment? And then additionally, like, how do we accurately identify illness, right? Like, how can we make sure if we don't test, how to figure out if somebody may have COVID or not, and then kind of what guidance do we give them? So one of the solutions that the Children's Center came up with was the development of clinical guidelines. These were algorithmic, they were updated on a regular basis, and they were disseminated through hospital epidemiology and infection control, as well as through the incident command center structure. And they were available via a link in the EPIC order. So again, to put yourself in the place of the clinician, because that's really where this study comes from, you would see a patient in the ED, and that's the setting we're going to find this conversation to. Let's imagine you're seeing a patient in the pediatric ED, and you know that you only have so many testing supplies, you're trying to conserve those supplies, and you're trying to conserve resources. And so now you have this algorithm that says, okay, here's who you should test. You can look at it for guidance, and then you can decide whether to put that order in EPIC or not. And as an example, here's one of those algorithms. This is actually the first algorithm that was put out system-wide at the different pediatric EDs within the Hopkins system. And just by glancing at this, though it's one page, you can tell it's actually fairly complex, right? So to go through it a bit with you, the first line there on tier 1, if a patient has respiratory failure and is getting admitted, they get tested, right? If they have 2 symptoms and they're getting admitted, they get tested. If they're at high transmission risk and have 2 of those symptoms or a positive contact, they also get admitted. But then you'll also see that there's a second tier here where if somebody has symptoms and has a chronic condition that would predispose them to potentially significant illness, they would get tested as well. But besides that, there wasn't a recommendation for testing. And I wanted to go through this one in more detail to show that the pediatric situation as a practicing provider in the PEDS ER context earlier in the pandemic was that you didn't test a lot of people. Most of the kids that came in, particularly for settings that didn't see a lot of chronic illness, you were telling them, you could have COVID, you could not, we don't know. We're going to recommend that you go ahead and isolate, and anybody that's been around you quarantines. And if you get sick or come back, you gave them anticipatory guidance to help guide their care afterwards. Now, of course, things change, right? Knowledge changes, resources change, things develop. And so this algorithm turned into this algorithm, turned into this algorithm, and then this algorithm, and then into this algorithm. And so now you add on top of these challenges the fact of a rapidly changing clinical environment with guidance in what's really a distributed system, right? So while we think of ourselves as one system within Hopkins, right, we have 3 pediatric EDs just in the state of Maryland. So excluding all Children's Hospital in Florida, they're not part of the research we're going to talk about here. We have Howard County, who serves a distinct patient population in Howard County. That's very different than Bayview and the pediatric combined unit that exists there and the patient population that it serves. And that's very different than the Children's Center downtown and the patient population it serves. So not only do we have algorithms within the central command structure being distributed to these sites, we also have 3 very different patient populations with different clinical cultures, different administrators, and the possibility of different implementations of those centralized structures in their localized context. And so for us, kind of looking at this, there's so many questions that come to my mind kind of about how we move forward and what we think about what happened. And so all these challenges together, here's some of those questions that come up, like how do we know that these algorithms are working? What about their implementation? How do they actually get put into practice? And how can we learn about that implementation process? What about adherence? We can put out algorithms. They were very much relied on in the centralized structure of pandemic response in the Children's Center. But that doesn't mean people actually use them. If you look at the literature on algorithmic adherence, you can find different things about how often or how tightly providers follow them. And then from my perspective, one of my interests often is in social disparities or health inequities. And when you have these 3 very different patient populations and the opportunity for 3 different kinds of implementation of the same algorithmic structure, how does that affect the possibility of disparities developing and who gets tested and who doesn't? And that's what led us to have this conversation around developing a data set, right? To start looking at this question and investigating it more. So we ended up having a conversation with Kevin and the COVID Kids team to develop this database that looked at the early stages of the pandemic, really those first 2 months. So from March 20th to May 11th are the dates specific to my study. Amyna's will be slightly different. The sites we wanted to look at were the Children's Center downtown, Bayview, and Howard County, particularly to those pediatric emergency departments there. And we pulled all encounters where children at any of those sites during those dates were either tested for COVID-19, they met influenza-like illness criteria, which is a defined CDC criteria that involves a number of symptoms I'm not going to go through here. But just to say it's a defined set of symptoms or criteria that matches the patient population and is in the literature, or that had precautions ordered. And the reason for those last 2 is that we wanted to identify patients who may have been considered for COVID testing and wouldn't have been tested based on the algorithms or clinical guidelines in place. And then we performed chart review. So we specifically performed chart review on all patients who were tested. And the goal of this was to see if testing was guideline concordant or discordant. So we developed a standardized tool in REDCap to do chart extraction. And then there was a process for resolving any questions or confusions around whether somebody may have a particular symptom or not. And basically what we're doing was we were getting all those data points in each algorithm a long time to categorize a particular test as, yes, this was according to the guideline, or no, this was not. And that's just what this says. And this was specific to the guideline in place at the time the test was ordered. And so that brings me to my interest here in this particular database and the question that I wanted to look into. And that's this question around equity. And there's, and in scarcity, this intersection, right? So there's a lot of different ways you could ask this. And there's probably at least 2 or 3 studies just in this database that I'll end up doing on this question. But the first one I want to look at is the question of, were children from a higher socioeconomic status more likely to receive guideline discordant testing? So again, putting yourself back in the position of a practicing pediatrician, you can imagine how if you're in the context of a resource limited environment, you're seeing kids who may have COVID, you don't know if they do or not, you may receive more pressure from some parents to test than others. You also may be in a different clinical context or a different socioeconomic environment where the culture is just different, and maybe there's more pressure to test. And so as these algorithms get implemented, does that possibly create some inequity throughout the system in terms of who gets tested on presentation, even when they shouldn't be tested? That's the basic sense. So this is a retrospective cohort study. The dates are what I listed earlier. And it involved patients ages 0 to 18 years old, seen at the Children's Center, Bayview, or Howard County Pediatric Emergency Departments. And for this study, particularly, we're just looking at those tested for COVID-19. We did exclude any patients that were transferred from one pediatric ED to another, only on the receiving end. We didn't want them to get counted twice. In terms of variables we pulled, just to specify, so we looked at date of visit, facility that they presented to, age, sex, race, ethnicity, their insurance type, right? So whether they had public insurance, such as Medicare or Medicaid, private insurers. When you see other listed, that refers to things like international patients, or if they were uninsured. We were able to pull their vital signs from the PMAP, though we also included data around symptoms from the chart. So if parents reported a fever at home, that was in the data also. We had receipt of SARS-CoV-2 testing and results acuity. This is based on a measure called the Emergency Severity Index, which I know many of you are familiar with. It's a scale of 1 to 5, where 5 means it's less acute, 1 means it's the most acute. The ADI, or the Area Deprivation Index, if you're not familiar with this, this is it's a measure of socioeconomic status that's based on 17 composite variables from the American Community Survey. And it's estimated using 5-year estimates from the ACS. The most recent version is the 2019 version. This is freely available online. It's done by Amy Kind out of Wisconsin. And lucky for us, it was actually already in the PMAP, so we didn't even have to merge it in, which is really nice. And so this was at the census block level based on where the patient lived. We had that guideline concordance variable we created. We had a variable for whether they had chronic illness or not based on our chart review. And then we also had disposition data. So we were able to identify 442 total encounters for those dates where kids were tested at those sites. And just to give you some perspective that gets at the implementation question, we also looked at total volumes at those sites for this study period. And I've anonymized the sites here, though if you really want to figure them out, you can. This is kind of partly for publication as well. But the first site A had 9.6% of the total encounters during this period were actually tested for COVID, or SARS-CoV-2. Whereas site B had 7.3% and site C had 35.6%. So right up front, you can tell something's very different there. Either there were a lot sicker kids showing up at one site, or there were just different implementations and different practices taking place. And we actually know from talking to the medical directors, because on our team, 2 of us work at these sites, and we talked to the medical director at the 3rd site, that there were different implementations. There were different processes that were put in place and different approaches to the algorithm. And so then we performed an analysis with descriptive statistics. We did a univariable analysis with the outcome being receipt of guideline discordant testing. And then we did a multivariable analysis with multi-level modeling. And I said fixed effects, but STATA actually determines the amount to which it's fixed or not. And then the outcome again was receipt of guideline discordant testing. And that multivariable analysis was to account for clustering by site, right? Because that impacts the modeling. And here's the table 1 of characteristics for children who were tested for SARS-CoV-2. So this isn't just those who were guideline discordant. This is all kids all 442 that were tested for COVID. And again, looking at the differences in site, you can see that they're very different by location. So most were tested at site C compared to the other two. And then you can see variation by age in who was tested at each site. You can also see just the differences in patient population by racial distribution and by insurance type, right? So if you look at, for example, site C here, they have roughly equal proportions of Black, white, and Hispanic patients. And then their insurance distribution compared to site B, for instance, they have a much higher rate of private insured patients, about equal though to what we see at site A. And then if you look at site B, the uninsured rate there is higher as well, 11.1% versus the other two. Also, looking at chronic condition, site A sees a lot more patients with chronic conditions compared to the other two locations. By ESI, there's also variation, though I would say that most of the patients listed here, right, are falling in the 2, 3, or 4 category at all sites, though more 2s and 3s at site A than at the other two, kind of proportionally. And then we looked at mean ADI, that area deprivation index, which is our primary measure of socioeconomic status here. And again, you can see very different by location. I didn't mention this earlier, but the ADI, the way it works on the state level, which we use the state level ADI here rather than the national one, is it's on a scale of 1 to 10, and 10, or the higher end of the scale, represents higher levels of deprivation, right? So for instance, looking at this here, site C sees the patients from the highest socioeconomic status, and site B sees those from the lowest socioeconomic status. And then again, with admissions here, most patients were admitted downtown. And so again, this just gets to the question we're asking, right? Like, these are very different patient populations. We have one clinical structure of an algorithm, and then we have these variable implementations. How does that impact the question around equity and receipt of guideline-supporting testing? And I want to step back for a moment and just say that one of my interests research-wise are what I think of as health structures, right? And what I kind of conceive as structural determinants of health. Like, we talk about social determinants of health, but when I mean a structural determinant of health, that can be something that shapes health for a large number of patients or a defined population by the way it forms practice or habits, right? So that could be something as simple as a road or a transportation infrastructure in a community, the ability to access a park. But it also could be something that we build like an algorithm and how it influences clinical practice and the shaping of health in that community context. And so I think of the algorithm here as the structure, and we're curious in how it's shaping this patient population and their treatment of illness. Okay. This table, I apologize, is slightly incomplete, and that's my fault because I didn't think to do it until 2 days ago. The thing I want to highlight here is this table shows by each site those who were concordant with the guideline versus those who were discordant with the guideline, right? And again, one of the things you can see up front here initially is that sites B and C did far more discordant tests than concordant tests, right? So there's difference in implementation there and in practice, just clinical practice with the guideline. Whereas site A had much fewer discordant tests compared to concordant tests and how they did things. And the piece of data that I apologize is missing here is that ADI, which would be really interesting to see, but that's my fault and not asking for it soon enough. I think I need to get out of jail free card from Laura because I've asked for so many things to follow up in the last few days. And she's been so kind and helpful. But I want to highlight here, again, that you can see some of the differences here in who gets tested by discordantly versus concordantly as well. Though there's not p-values here, and again, I apologize for that. But we'll still see things in the univariable analysis. So I did want to show this. So here's the univariable analysis for the whole population, looking at the associations of patient characteristics with their receipt of guideline discordant COVID testing. And the first thing we can see is that age as a categorical variable is significantly associated with guideline discordant testing, with patients 0 to 12 months and patients 12 to 18 being more likely to get a guideline discordant test. And we could maybe theorize around why this is, right? Initially, the guidelines didn't account for the use of SARS-CoV-2 testing in febrile infants or neonates. And so it would be really reasonable for somebody to discordantly test there in that context. Another explanation for the 12 to 18-year-olds may be that site C just saw a lot more of them and was doing a lot more testing. and that led to more guideline discordant treatment in that population. You'll see clear differences by facility, right? And whether somebody was likely to receive a guideline discordant test. And this is important because it means that where you went influenced what you got, right? And gets to that question around equity. And then no difference by ADI, interestingly. So even though we had very different populations at each site, it was not associated with socioeconomic status based on this analysis. And then no difference by guideline in place at the time, no difference by race or ethnicity, no difference by insurance status, statistically speaking. And then by acuity, a slight difference in the lower acuity patients were statistically significantly more likely to receive guideline discordant testing. And again, I think that's probably just from the volume at site C more than anything compared to the differences in ESI with site A. So that's univariable. When we adjust and we do that multi-level modeling that adjusts for clustering that I mentioned earlier, we don't really see that big of a difference overall. So again, age, we see the same significance. And then in location, they remain significantly different with sites B and C having more discordant testing compared to A. And then by guideline, no difference. And then by race and ethnicity, no difference. And in our final model, those are the variables we included for, based on pre-theorized pathways. We did check for any collinearity, and that was there was no collinearity in this model. And then for anybody who's interested in more the theoretical basis, we based some of this analysis and some of our thinking here on the WHO social determinants of health model, which I found very useful in thinking through these things. And so in conclusion, there was no statistically significant difference in the receipt of guideline discordant SARS-CoV-2 testing by socioeconomic status based on the ADI. However, there were statistically significant differences by facility and age, which I still think are relevant in that, one of the goals was to try to standardize some things across the institution in our response with the aim of conserving resources. And we'll get more to that in a minute. However, I also think that it's important to consider that blind adherence to an algorithm is not the outcome we want to see here either, right? And so it's expected that we'd see some non-adherence. We actually saw quite a bit here in guideline discordant testing. But there also could be something to be said for saying that it's appropriate, and it's not just expected, but appropriate to diverge from what a guideline recommends based on a local context or as knowledge develops, particularly in this kind of pandemic setting. So some implications here that I just wanted to put out there for the system. So centrally governed large health systems face challenges in local implementation that can negatively influence equitable resource use. I think we see that here in some of the data. Did it have a massive impact on the system? Probably not. But it certainly had some downstream impact on patients in that, the same patient, if they'd gone to Howard County versus Bayview versus downtown, wouldn't have necessarily received the same care. In terms of what they would have gotten for COVID. And then the next point, which I mentioned just a bit ago, is that clinical algorithms require discernment in their application. I think of this particularly in response to the fact that those 0 to 12 months old received more guideline discordant testing. I think that personally, that was probably an appropriate deviation. And I think this caveat is even more important in this kind of resource constrained setting with limited developing knowledge. Some limitations, right? So this is a single healthcare institution. It's in a single state. And that was intentional to try to account for controlling variability, right? Including all children's would not be feasible for a number of reasons, but also would have led to some challenges there. And then additionally, given that we did chart review and a lot of our defining of guideline concordance was based on that chart review, there's certainly a possibility of categorization errors based on that. And so with that, that's the conclusion of my part of the talk. I saw that there were some comments in the chat, but I have not had a chance to look at them. And I see there's some things on here. So Dr. Millstone. Oh, yes. So there was an initial period that is not included in my data that required approval from an on-call physician for test ordering. I believe, and Amyna, you can correct me if I'm wrong on this, that was just the period prior to 320. And that's partly why I cut off the dates starting at 320. We do know that by 320, that was the period where there was a defined algorithm in place. But there was also certainly greater oversight. I know at downtown, I do know at Bayview, we also, at least in the dates prior to 320, had to call to ask for approval. Though once the algorithm came out, I don't recall that being the case. Any other questions or comments? Something else in the chat. Would you have been able to conduct this entire project using PMAP without manual chart review? You know, I was actually thinking about that some this morning, and I would say if I could do natural language processing, probably. That is not in my skill set. I enjoy research, but I do not have the time to learn natural language processing right now. So, but if it would have been possible, yes.
Yeah. No, very specifically because of the unstructured data in the charts, in the notes. That's what we had to go back and actually read through the notes and get, for instance, duration of fever, which wasn't easy to get otherwise without natural language processing in the from the notes. And I'll point out too that one of the ADI was one of the really, I'd say, very helpful additions from an external of data from an external source being added to the PMAP data core. And the reason for that is Ailey Klein, basically at the Center for Data Science, was the one that was able to pull those for us very separately. He'd used them for other studies, but was able to pull them very directly for this particular study. So again, one of the strengths of PMAP in being able to link external data to the rest of the clinical data that we're using into a data commons.
Well, thanks for the opportunity to present the work, and I will hand things over to Amyna then.
Hi, everybody. So yeah, we actually talked about doing the natural language processing when we were kind of beginning the studying and seeing if that was a possibility, but I think it was in the early works at PMAP. Not sure how much that has advanced, but again, like with this study, some of the vocabulary that's used in the charts might be a little different than the exact words we're looking for. So the chart biopsy takes a little bit of like clinical understanding too of, you know, the symptoms that we're looking for. One of the things, for example, was shortness of breath is one of the lists of symptoms. But do we consider wheeze as one of the shortness of breath symptoms or not? And that was actually a debate even within our ED. So something that we had to come to a common agreement on. So I'm going to share my slides, and definitely wanted to give that also thank you to Anna Samuels for kind of helping us look through the algorithms and giving us a little bit of context behind that as well. And I thank Dan for giving us the context of the situation at the time. It definitely was a long time ago, and hopefully some of us have forgotten that time period. But there was a numbers that came out during that time that I'm not sure if everyone remembers, where we were hearing that from Seattle Children's, there were somewhere around like 400 children that were tested for COVID, of which only 6 turned up positive. And that was kind of the thought process of time, that children were really not getting infected by SARS-CoV-2, and were at least not having the morbidity and mortality. And of course, that has changed over time, and our understanding of SARS-CoV-2 has changed over time. That being said, the fact that we did have a low census did give us the ability to do that kind of manual chart review. Otherwise, it definitely would have been a lot more cumbersome. And we were honestly strictly looking for symptoms to be able to address whether the algorithms were used effectively or not. My vantage point comes from disaster management and trying to see if the processes that we put in place were actually effective, and could they be effective, helping kind of with the algorithms and monitoring them at one of the sites. And during early COVID, we saw this frequent turnaround of the algorithms where we were even kind of like holding our hands up, like, okay, we need to give everybody a day of breathing before we change it again. And it kind of felt that rapid pace changing of all of the kind of our protocols in many places, and with new information that was constantly coming out. We had an incident command for the entire health systems, as well as Johns Hopkins Hospital. And we also put up an incident command within the Children's Center that was new to the Children's Center, and was reaching out to also manage and monitor the children outside of the downtown campus, Bayview campus, as well as Howard County. And we were actually interacting with All Children's Hospital. So how effective was our communication about the algorithms that were coming out, the communication about the changes that were happening? As Dan showed, the algorithms, that was one of them, but they were all just as complex. And as time went on, we were adding new pieces of either symptoms or contacts or travel. There was many more decision points that were happening with each algorithm. And was that something that was playing a role in our ability to use the algorithm? And then, as we were saying, the Incident Command Center definitely had a role, in one of its roles is to have oversight of the resources that are being used under its system. And were they having oversight of the algorithms which were meant to manage the resources? And so if you think about it, our resources were so scarce that we wanted to make sure that the people who were needing it were getting those tests. We actually only had, and I remember at one time, there was only 100 tests that were available in one day for the entire health system. So, do we want to be using them on all the children that are coming in who are more likely to be negative and more likely to have no morbidity or mortality from it? Than using it on adults that we are going to need it for a lot more. And it's not that we couldn't still use them on the adults, but the adults or other people would be waiting a longer time to get their results back. So where is it going to be most impactful? So that question was specifically, did the algorithm complexity or duration, or the instant command communication or oversight of the algorithm use contribute to some of the discordant testing or testing of children with the SARS-CoV tests when it was not indicated by the recommendation? And my inclusion were very similar, except that it was I was including the earlier days, and only because that does speak to the ability of an incident command system to be put up and give that oversight and direction in a very quick manner. And the exclusion, again, were just duplicates, so patients that were transferred from one of the hospitals that we were including to the other ones. For the study, with the help of BEAD, we did descriptive summary statistics. We were looking at comparison analysis with chi-squared, students t-test, and did a sensitivity analysis to see if, to help determine if the duration of each algorithm played a role in the discordant testing. And briefly, this is kind of the table that you've seen before, just laid out slightly differently. And for my numbers, all of the patients that were tested, there was 1,132 that were tested, of which 289 were tested discordantly. That's 56% of the ones that were just tested discordantly, which is actually a much higher number than we had expected. We saw that there was a significant difference with age, and the younger population was tested a little bit more discordantly. Chronic conditions was part of the algorithm, so something that we, again, expected. There was a difference in acuity, so definitely a little bit a difference in the patients that were level 3s and 4s that were tested discordantly. And the facility was one of the major differences that we saw. And we anecdotally spoke about that during the pandemic itself, but it was interesting to see the data and see how that looked. And facility A had a little bit more oversight, and facility B had small numbers. Facility C had a little bit less oversight in general, and that's after discussion with some of the emergency managers that we had at each of the sites. Just to give you an idea, I'm going to actually skip down to the bottom part here. These were the algorithms. Actually, these are going to be slightly different because we found one that was possibly used. We had a lot of drafts that we were kind of working on back and forth and with HEIC, and there might be a possible other algorithm that we would include in this. But the general theme kind of still pertains to that. We saw the discordant testing actually went down with time in general. And at facility A, facility B, the numbers again were low, but the discordant testing stayed not fairly similar until the last algorithms. Again, noting that as each subsequent algorithm went on, the amount of children that we were allowed to test became more liberalized. So it could be one of the reasons why we were seeing less discordant testing with subsequent algorithms. Now, kind of looking up at the top part, seeing that we had 50%, 56% that were discordantly tested, the least number at the downtown campus where the incident command center was held, and a little bit more at the other facilities. And the number of positive patients that were discordantly tested, there was 35. How impactful is that if they were positive, if they were children, if they had a lower morbidity and mortality when you look at it from an individual standpoint? And this is kind of the interplay between, individual medicine, public health, and disaster management, where then you have, maybe it's impacting the families. So this child's going to go back to a crowded home with elderly. And is it better for them to know? But if they can't do anything about it, how is that going to help the situation? Still, maybe better to know. And that's why we're all very, working with HAIC, very happy when we were able to liberalize testing more so that families can be aware and whenever possible, be able to isolate and help out the rest of their family, or if they're going to work and spreading it, or, for other people in the family to be tested. But as you can see, that the numbers were, even though facility A had the lowest number of percentage of discordant testing, it actually had the lowest number of discordant positives as well. Whereas the other kind of end of it is facility C that had the highest number of discordant positives and the highest number of discordant testing. So, there's theories that we have on why that might be so, and with discussions with the emergency managers of the area, each site, but we don't have a true data to back that up. We do and some of those things that the emergency managers were saying might apply throughout each of the facilities. And just to put this in graph view, and I apologize for not having these labeled as A, B, and C, but just in general, all of discordant testing went down over time. This one was the downtown campus, and you can see that definitely fell drastically, and so did the facility C. So from each facility, kind of talking, a part of our discussions that we had, did short interviews with the emergency managers. There was at the facility C, there was definitely an understanding that, their population might be, they felt that their population might be different, as they definitely have patients there that might be having crowding in their home, and multiple families living together that might be contributing to their desire to test more patients that came in, pediatric patients that came in. But in all, and then also for the algorithm duration, we did the sensitivity analysis and found that the duration of each algorithm did not impact the discordant testing. So whether an algorithm was in place for 7 days or if it was in place for 13 days, it didn't impact the amount of discordant testing. The only thing that the biggest impact for the algorithm itself was the liberalizing of the patients that could get tested, then leading to less discordant testing. So the complexity is there wasn't a significant difference of the discordant tests. There was one between the facilities, and one of the theories is that, if we improve communication oversight, then we can improve the use of the algorithms widely. Maybe there wasn't great communication between the incident command and oversight of these areas kind of throughout that scarce testing use. And then what I was impressed by, and one of my theories was that, our hypothesis was that the algorithm complexity and duration was going to affect discordant testing. However, we found that that was actually not the case. And one of the thoughts is that this study was done in emergency departments with healthcare workers that are used to seeing high-paced changes in their just regular clinical care, and are kind of bred to be very adaptable. And that's possibly why they were able to handle that rapidly changing algorithm use. And the same limitations apply to the study as we were using the same data. But that's just 2-3 examples actually of how we could use the PMAP data to find out, multiple questions about how we were doing during this early kind of pandemic phase. Is there any questions about kind of the last study that we did? Any other questions in general about the PMAP database?
All right. Well, I think Laura did put the link to the website for PMAP in the chat, but I'd like to point out that specifically we're the Center for Data Science is a specific team that uses PMAP, but there are multiple other teams that use PMAP, and there are multiple other ways PMAP can be used. And it's available, PMAP is available for individuals to use or entire teams to use. So it just happens that the Center for Data Science is a precision medicine center of excellence. And so that we have an entire team dedicated to using PMAP for, or at least using the big data overall that we get from our electronic health records for improving patient outcomes.
Thank you so much, Kemi, and the rest of the team. This has been incredibly interesting and helpful. And I want to make sure you guys see in the chat what Sharon wrote about a new geocode table being available. And the great thing about PMAP too is they're constantly creating new curated tables based on different research that's being done. So it's really a wonderfully quickly developing resource that people can use. So thanks again to the team. And again, anyone who wants BEAD services, please reach out to beadcore@jhmi.edu. Any last questions? All right, well, thanks again. That was really wonderful. It's so interesting, and I've enjoyed working with you all so much on this, and I look forward to continued partnership and seeing what all we find out using this wonderful data. Thank you.
Thank you, and thanks everyone.
Thank you, Laura.